we have Dr. Orloff. Hello, how are you, Dr. Orloff?
Hi, everybody.
All right. Well, like I said, this is Dr. Marlena Orloff. She is joining us all the way from the other side of the country on the East Coast in Philadelphia at Thomas Jefferson Hospital with the Sydney Chemo Cancer Center. So, Dr. Orloff.
I think Dr. Barry, summed up things great there just in the last few minutes that, there is a little bit of a baton pass, that happens after a patient has a new diagnosis of metastatic uveal melanoma. Normally that baton pass is kind of most seamless when the patient already has a relationship with a medical oncologist. And I'll talk a little bit about that, but we certainly are grateful for our ocular oncology colleagues who will also pick up the phone and call us if one of their patients has a new concern. So thank you, Dr. Barry, for kind of setting the stage, and we will jump right in. So as Danae mentioned, the title of my talk is Navigating a Metastatic Uveal Melanoma Diagnosis. So what I wanted to do is really kind of set this talk up in chronologic order, kind of based on how one actually experiences a new metastatic diagnosis. And so I don't necessarily go into detail about surveillance and what leads up to the suspicion. I think part of that was part of Dr. Barry's talk. And then also today is really not meant to be a discussion of all of the data, including recently reported trials or trials in progress. I actually encourage you, there's lots of other webinars I think that have been on this topic. And I will say that actually here at Jefferson, we're having a patient symposium for which a Cure Insight's actually going to be there just tomorrow. You can only attend in person, but it will be recorded and then available online as well. Where kind of each of the treatment approaches to metastatic disease actually has its own session. So a lot of the information can be reported there and has been also detailed elsewhere in other webinars. So really, like I said, today is really just kind of going through, the navigation checklist of kind of what the steps are that someone may experience and kind of how to think about those if you're in the middle of it, going through this, or certainly, unfortunately, have to go through it in the future. So here you can see kind of an outline for the talk. So, with things like Epic and other electronic medical records, it is honestly often the patient who gets an alert on their phone that a radiology read is available for review and may actually see the report before the physician. Certainly, if my patients are getting their scans outside of Jefferson, it's going to end up in whatever local portal exists there before it ends up getting either electronically sent over to my in-basket or even old school paper fax and then uploaded. And so, what I wanted to kind of highlight here is that, that you get the alert that the MRI report is ready for review. And for those of you who've had the experience of reading MRI reports, you want to scroll down, you want to see the impression saying, no evidence of metastatic disease in the liver, right? That's what we all want to see, every time we get a scan. But unfortunately, there are times where even if you've had a bunch of negative scans, the impression is not that. And the impression may be something as kind of definitive as, extensive hepatic metastasis with, a large mass. It may even suggest that there's cancer outside of the liver, and what that translates to is what you can see here on the right is, this being an MRI, this being the liver, here the brighter white being normal liver, and then the dark spots here, these circles being tumor, and then actually this whole left lobe here is a tumor. So this is not subtle. There's no kind of clinical confusion about what's happening here. We would still offer biopsy for this patient to confirm, which we'll talk about in a second, but this is pretty obvious. On the opposite end, there are times where a patient could have had an MRI, multiple MRIs, or maybe their first MRI. And the impression is there appears to be a new lesion in the left lobe, measuring often under a centimeter, but given the history of malignancy, METs cannot be excluded. Close interval follow-up is recommended. So here the radiologist is actually saying, while we think this could be METs, close interval follow-up is recommended. And there are times where close follow-up is recommended, but, oftentimes we do actually aim to biopsy these. So if someone's undergoing close surveillance, so certainly the high-risk patients who are being followed, say, every 3 months with MRI, it is not uncommon for an MRI to pick up something that's new under a centimeter, in which case biopsy may be difficult. Sometimes the urgency for a biopsy may be dependent on how suspicious something looks, the size of it, the location. Though we tend to say that anything new or growing, certainly in the liver, needs to be evaluated and biopsy at least attempted. If it's outside the liver and it's a lung nodule, we often actually monitor those, I would say, for longer. Someone may have a couple of new 3-4 millimeter lung nodules. It is unlikely that's usually related to uveal melanoma. Not to say that it's, never uveal melanoma, because we certainly have patients who present with lung metastasis first, and that's like a whole different kind of subset of patients. But there's also a lot of other things that can cause lung nodules, bad bronchitis, or, certainly we were seeing it a lot during times of COVID. So not every lung lesion is uveal melanoma, but, in someone with history of eye melanoma, it's usually any newer growing liver lesion really is uveal until proven otherwise. Lung lesions, if they get big enough, over a centimeter, and we will often recommend a PET scan, which we normally don't do, at least in my practice, for the liver. And I would say of all the patients that I've evaluated for uveal melanoma who've had a new lung lesion, I've probably actually picked up incidental lung cancer, probably more than first diagnosis metastatic uveal melanoma. So they still need to be worked up, still need to be biopsied if suspicious, but they are a little bit of a different breed. In our practice, basically because we, I have an interventional radiologist who's very good at ultrasound guided biopsy. If a lesion is greater than 7 millimeters and location appropriate, biopsy is often feasible. If it's sizable, but the location's hard for ultrasound and percutaneous biopsy, we sometimes send to a surgeon for an exploratory kind of laparoscopy where they can look at the liver and get to areas, sometimes even use intraoperative ultrasound to get a biopsy there. But if it's small or hard to access, then actually scans at 2-month intervals, so that close interval follow-up that the radiology suggested, can be reasonable. Even if we can prove metastatic uveal melanoma for a lesion under 1 centimeter, it does actually pose some challenges for treatment decisions. So often things under a centimeter are too small for clinical trial, sometimes even too small for certain liver-directed therapies. And, we'd certainly have patients where we may say, let's wait until it's over a centimeter to biopsy. Or even if we biopsy it at 7 millimeters, we say, but there's a first-line clinical trial that we really want, to wait for, so we may get another scan and wait for it to get over a centimeter, which I know seems crazy. And for those of you listening who've kind of been in that limbo, it's an uncomfortable place to be, but it is a little bit of kind of a diagnostic and then kind of treatment conundrum that we sometimes find ourselves in. The truth is, though, if lesions are multiple and sizable, you shouldn't be waiting to biopsy. And I guess this also goes to the point, and I didn't put a bullet here, but it is our practice that we do not treat without biopsy confirmation. There have been patients over the years that, even though it looks like uveal melanoma, it turns out to be something else. So sometimes you pick up things like chronic granulomatous disease, which is kind of a type of inflammatory process that can happen in the liver, in which case, we obviously would not then treat for metastatic uveal melanoma. So biopsies are necessary, certainly required for clinical trials, and then required in our practice for treatment. So the next thing kind of in the checklist that I had mentioned is something called HLA testing. So I think for those of you who are not new to the uveal melanoma community, heard about HLA testing. What is HLA and why does it matter? We'll talk about that. So HLA stands for human leukocyte antigen, also called MHC. It encodes cell surface molecules that are basically responsible for presenting bits of antigen to T cells. So antigen can be bacteria. Antigen can also be tumor. And the immune system really kind of uses HLA to differentiate self versus non-self. But here in kind of cancer fighting terms, it's really the MHC or the HLA that presents bits of cancer to the immune system. And then in theory, the immune system should recognize it as being a bad guy and kill it, as you can see by the diagram there. So why does it matter in uveal melanoma? Well, because really the only systemic drug that's specifically approved for uveal melanoma, something called tebentafusp, is what we call HLA restricted. So in order to be eligible for tebentafusp, you need to be specifically HLA A201. And so testing for this really should be offered to all patients either in the surveillance period or at first metastatic diagnosis before treatment decisions are made. There are many different types of HLA. And so in order to develop kind of this drug drug that you can kind of see here. It's kind of this ImmTAC, this blue guy here. It needed to basically be engineered to interact with a particular HLA that would present the peptide, because there's this linking that has to happen in order for the T cell to then kill the cancer cell. And HLA-A2 is the most common, found in all ethnic groups, and O201 is the most common in Caucasians, and of European descent, which make up a bulk of patients who are diagnosed with uveal melanoma. So I just wanted to kind of take a step back, and I think Dr. Berry started to kind of allude to this, and that why it's so important to seek care at an expert center, or have a medical oncologist who's in touch with folks at an expert center, or even if you have a local oncologist, to kind of have your foot in the door at an expert center. And that's really because, in uveal melanoma, it's rare. You've probably heard about the incidence and prevalence, not only in Dr. Berry's talk, but elsewhere. But in the metastatic realm, there's really growing complexity in the treatment landscape. And so I think it's really important to be at a center that has knowledge, at least, of the broad landscape. So, not only knowledge of melanoma as distinct melanoma subtype, obviously different from skin melanoma, knowledge of treatment indications and criteria. So, knowledge of what HLA is and why having that information is important, knowledge of standard of care treatments and ability to offer or refer when unable to offer. So, not every oncologist in the US is able to offer tebentafusp. It is a little bit quirky and unique in that there's, some inpatient hospitalizations and prolonged monitoring period with the first 3 doses. But at least if a site is aware that the drug exists, if they can't offer it themselves, at least be able to refer to a site that can. Knowledge of clinical trials that are open now and in the near future, and really knowledge of inclusion and exclusion criteria of those trials. So, the last thing we want patients to do is to get a treatment, say, immune checkpoint inhibition kind of as a first choice, because the medical oncologist may not be aware of what's out there, that then makes them ineligible for a trial. We do have a first line trial right now that I'm going to detail that's very specific to A2 negative patients, but you can't have had prior immunotherapy because that's actually a comparator arm. So, you don't want to be somewhere where something may be offered that then could exclude from treatments down the line. And you don't always have a crystal ball, but at least someone who's, willing to, like I said, reach out to an expert center who may have those ideas. And there are opportunities to seek recommendations from an expert center and then get treatment closer to home. So I gave the example of tebentafusp. So there's a lot of sites that may not offer the first few doses because of the complexity of the prolonged monitoring period. But we have a number of patients, actually probably almost 3/4 of our patients, who come get tebentafusp induction at our site. We then actually refer to an oncologist closer to where they live. And that works out really well. Standard of care immune checkpoint inhibitors. So if things like your Opdivo, Keytruda are recommended, those can certainly be done closer to home. There are some liver-directed therapies that can be done closer to home. Obviously now with Hepzato being FDA approved, in theory, it could be done kind of anywhere, but it's also kind of a unique treatment and it's not necessarily being offered everywhere. But things like radioembolization and Y90, because it's offered for other cancers, often can be offered at a local hospital. However, despite kind of having some of those options, as many of you know, there's still often a need to travel for clinical trials or even sometimes just basic treatment. And just sometimes really just the comfort of being somewhere where that even if you start on treatment A, they could potentially offer you then treatment B and then treatment C and not have to be kind of going to multiple sites. So I started really framing a lot of my talks kind of around this, because this is really what ends up going into the decision making, both kind of with the patient and then also actually behind the scenes. When we talk about patients and talk about, what treatment approach may be best, there's really 5 things. So HLA status, which I'll go into a little bit more, though we already talked about it, the sites of metastatic disease, how quickly things are growing and how much tumor there is. So what I call burden and kinetics, clinical trial availability, and then really something I've kind of titled as logistics. And so these are all kind of things that we kind of throw in the pot, when we're trying to decide what treatment may be best for a patient. So one of the first breakpoints, as we noted, is HLA status because of the availability of tebentafusp. So if someone's A201 positive, they are eligible for tebentafusp. There are other HLA restricted options. So there are other clinical trials that may enroll specifically A201. And then there are actually also trials now or soon to be enrolling for another subtype subtype called A24, which is kind of one of the more common subtypes as well. So having your HLA type, not just knowing if you're A201 positive or negative, but actually knowing kind of what HLA-A alleles you have could be helpful for treatment options. And then if you're A201 negative, in theory, all of the other options outside of those that are restricted to A201 are an option. And then very specifically, there are trials for patients who are HLA A201 negative. So having that information out front right before, before first line treatment is really important. So the current options to treat them kind of based on HLA status, I already kind of said this in so many terms, you can see it here. And, tebentafusp, again, I'm not going to go too much in detail. There are full hours available online where you can learn all about tebentafusp and other webinars. But more recently, we did publish the 3-year overall survival. Tebentafusp was compared to the control arm, which was single agent immunotherapy or chemotherapy. And what you can kind of take home from here is that even going out now 3 years or more, there's still kind of a break in the survival curve. So with more patients alive in the tebentafusp arm than the control arm. Some of the other things, that were originally reported haven't changed a whole heck of a lot. We still don't see a ton of response with tebentafusp. So you can see, only one patient had a complete response, patients who've had partial response, but a lot of patients having stable disease, especially when you compare it to the control group. And it's really these patients too with stable disease, or even if their best response was progressive disease and then kind of plateau, still showing kind of an improvement in overall survival compared. And then this is, again, just showing that even patients who have progressive disease tend to do better than those who had progressive disease in the control, probably due to phenomena and sometimes progression before kind of plateau or other things that we still haven't totally figured out. And then what you see here is, in case this has come up in discussion with any of your medical oncologists, is that at least on the trial, we looked at something called circulating tumor DNA. And there was a thought that correlation of kind of outcome and survival with log reduction in circulating tumor DNA correlated better than actually radiographic response. So there are some folks that are checking ctDNA kind of in practice. The platform that was used in the trial is a bit different than the one that's commercially available. So it's hard to know if it'll kind of stand up compared to what was done in the trial, but for some patients, it can be a useful tool. So like I mentioned, there are other HLA restricted considerations. The most common HLA in most of the trials will restrict for A201, but they'll look out for an expansion to A24 and potentially even other HLA types. So even if you are not A201 positive, like I mentioned, there is a first-line trial that's actually enrolling specifically A2 negative patients. So this is the randomized trial looking to get kind of registration or FDA approval of the combination of darovasertib and crizotinib. So it's a 2-to-1 randomization. You need to be A201 negative, and then you're randomized to either get darovasertib and crizotinib or investigator's choice, which I think for the most part, at least in the US, is Yervoy and Opdivo. So why are we excited about darovasertib and crizotinib? And that's because, we've been doing the trials for actually quite a long time, initially with just darovasertib, also called, some of you might have heard it as IDE 196, and then in combination with crizotinib, which is actually a drug that's approved in lung cancer. And when we were doing the other trials in patients who've been previously treated, you can see by these waterfall plots that the majority of the patients were going down. So that means the majority of the patients had some shrinkage of tumor. Anyone kind of over this negative 30%, that's considered a response. So you see an overall response of 45%. This is first line. 95% of patients had shrinkage, disease control 90%. And here, this is any line. So patients even who have been previously treated. Here an ORR, overall response of 30 at 92% at tumor shrinkage, disease control of 89%. So, these are numbers that we've never seen before in uveal melanoma and metastatic uveal melanoma. So it's very exciting. So the hope is that this drug will get approved following this trial. I will say, and some of you have heard, and I think it's been shared kind of in some of in the online support groups and whatnot, that even though the first line trial is restricted to A2 positive or A2 negative patients, there may be an opportunity soon for patients who are A2 positive who got tebentafusp to be enrolled not on this trial, but actually on an arm of the original trial that is actually shown here. So more to come on that. So the other thing that I like to consider, when deciding which treatment option first is where the tumors are. So as many of you know, patients with metastatic uveal melanoma, the first place that it likes to go, and often the place that can become life-threatening, is in the liver. But there are patients who have either extrahepatic only or extrahepatic dominant. They may have a couple little liver lesions, but they, have a whole lot of stuff going on in the lung. So that is a decision point. So if they're intrahepatic dominant, you may want to consider liver-directed therapy. You can also consider systemic therapy or even combination. And then extrahepatic dominant, you're probably going to want to choose a systemic therapy. So as I mentioned, I would say more than 90% of the time, liver metastatic burden is really what's dictating survival. Some treatments have restrictions regarding sites of disease. So PHP, taste hepatic perfusion, Hepzato, really limits the sites of extrahepatic disease. So you can't really have like a whole lot going on in the lung or a whole lot going on in the bone. You can have some sites that may be amenable to radiation, but not a lot going on. Other liver-directed therapies, we tend to be less stringent. There are trials coming that you need kind of injectable disease. So that'll kind of be a parameter that needs to be considered. Rare to have extrahepatic disease only. Often it can be associated with, lung as the primary site. There's a specific mutation called SF3B1, where sometimes we see in those patients tend to have lung first, at least. There tends to be kind of a better prognosis overall. And though many patients may start with extrahepatic only, most, if not all, kind of eventually develop liver metastasis, which even if you started with stuff outside the liver, it's still sometimes the liver that becomes what's life-threatening. And then the important thing is that there's a number of trials that are coming out to address groups of patients with combination hepatic and extrahepatic disease. I mean, it's just the reality that that's often what we see, and we need treatments and trials that address that. So just a few slides on PHP and Hepzato. This has been discussed kind of for years. Most recently was FDA approved almost a year ago now. And then the publication actually just recently came out looking at the efficacy and safety really of just the single arm. So there was kind of two arms in the trial, but this is really a publication on the patients who got PHP. So, here on the left lower hand corner is just kind of an illustration of what PHP is. It's a catheter system essentially that kind of closed circuits the liver so that you can perfuse the liver with chemotherapy through the artery. Then the blood kind of goes through the liver, collected in the big vein. But because there's a balloon at the top and the bottom, the blood just kind of goes in the middle, so it doesn't go to the rest of the body. Then that blood is kind of sucked out, put through a filter system, and then put back into the body. And this can be done up to 6 times, typically every 6 to 8 weeks. So here you can just see a snapshot. And again, this publication is now out of how patients did. So there were 7 patients who actually had a complete response, 26% that had partial response, and then another 34% that had some stable disease. You can see duration of response, the 1-year overall survival, 80%, which is pretty impressive here. Overall survival, 2 years, 43%. And so, and then they're specifically hepatic kind of endpoints are really just looking at the liver. And so with an overall response rate, so kind of percentage of patients in which the tumor did shrink, 36%. And then this is a survival curve of showing patients who had the complete response. Obviously their survival was much better compared to those that even just had a partial response or stable disease, but being better than patients who only had progression. And, while it's not in this current publication, in some of the original presentations that are available, I think, online, this looked better than the patients who were treated in the comparator arm, which was mostly just chemo embolization, but of various kind of types because it was dependent on the location. So, I would say other than HLA in that first breakpoint, and maybe even more so, at least at our institution, kind of overall tumor burden and how quickly things are growing probably weighs the most in how we decide on treatment. Because if you have a patient who has bulky tumors, large tumors that are growing quickly, sometimes you got one chance. And so, you don't want to delay, you don't want to kind of make the wrong first move because that can really affect what happens down the line. So, we often take this parameter very seriously in making recommendations. So if tumors are big or growing quickly, really want to be able to start something quickly. So unlike what Dr. Berry said about the primary eye tumor, where, a delay of a couple months probably not going to change much, here, In metastatic uveal melanoma, sometimes tumors can double in a week. And so if we have a couple of time points that are telling us that's how quickly things are growing, you need to start something quickly. And ideally, we would also start something that has a higher response rate, right? If you're starting out with a lot of tumor, you want to be able to shrink that tumor. Whereas if there's limited tumor burden, or you now have a couple of scans where things are growing slowly, because that does also happen, then really all options should be considered. And we should be looking at all the other parameters that I mentioned. And so going back to those two kind of cases here, if it's really just a solitary tumor, not even a centimeter, some treatments may actually be reserved. Meaning if it's not quite a centimeter, you may not have a clinical trial. Certainly if they're ALA2 positive, first line tebentafusp for these patients makes sense. There's certain liver-directed therapies that we don't necessarily recommend if there's really just one solitary, 1 centimeter tumor. And then the thing that does sometimes come into play here is if there's really one tumor, and we always kind of make the rule, there needs to be a little bit of time between the eye diagnosis and the scan, because sometimes you just want to make sure it's not like just the tip of the iceberg type thing. And also like to see it at least on a couple of scans that there's really just one. That's when things like ablation can be appropriate. So, and I say ablation almost kind of loosely here now, because there's a number of different things you can do. So true kind of microwave radiofrequency ablation. There's other new strategies for kind of targeting solitary lesions. Sometimes just focused radiation if ablation's not able to be done, accessed, that those can all be offered. If the tumors are large and growing quickly, want to start something immediately. Percutaneous hepatic perfusion does have an exclusion for greater than 50% involvement. Clinical trials, while we love clinical trials, there are patients that can't wait a month necessarily. And we have all, us, who do clinical trials in the space have all seen patients that were referred for clinical trial, and the time it kind of takes to kind of get the patient there to do a little bit of the screening, all of a sudden you've lost control of the liver, and that can be an issue. You're, watching liver function very closely in these patients. You can offer debulking with chemo embolization, which is often kind of at our institution what we offer patients with very large tumors who are growing quickly, because that's sometimes our best chance at kind of stopping things until we have a very effective systemic therapy, which, going back to just, bring up the Darrow Crizo story, if these pills really show us that we can shrink tumors in that percent of patients, that may also be a good option for those patients in the future. We know that patients who were on the trial who had bulky disease, so we call M1C disease, which means largest tumor greater than 8 centimeters, those patients did not do well with tebentafusp out of the gate. Ipi-Nivo has, kind of a lower overall response rate than we would like to see. Patients can get that locally. So normally if there's a patient who has a lot of tumors progressing, maybe symptomatic, if they can't get to, an expert center for, something else, sometimes those are the patients we'll recommend just start Ipi-Nivo locally, because normally that can be started within days or a week. Larger liver tumors, those patients can be symptomatic. So we also want to make sure that they're not having nausea or vomiting or pain, and may refer to palliative care for help with management of that. So just a little note, about chemo embolization. Again, we offer that quite a bit for patients with really large tumors who are progressing quickly, and have shown in various publications over the years, patients with, here the darker spots or tumors. This is a before, kind of an after. You don't really see that big guy. It kind of shrunk down here. And here's another one that was treated with something called Debdox, which is a type of chemo embolization, followed by more standard. So this is a big, my cursor's on the wrong side. There's a big tumor right here. And then this is 15 months later, the tumor shrank kind of significantly there. So this is an option for some of our patients with larger tumors. And I mentioned ablation for kind of solitary tumors, or, I think what we also say is patients who have kind of oligometastatic progression. So they had, 10 tumors and only one was growing. Sometimes we'll also ablate those. And we often, like I said, typically reserve, I think this 3-year mark is probably a little more liberal now. But certainly if a patient, say, just had plaque radiation or nucleation, say 2 months ago, and now they have a solitary lesion, that's normally not a great sign. Normally other lesions are going to pop up soon. But if it's been 2, 3, 5, 7, 10 years, and we're really just seeing one solitary lesion, and then often they're a good potentially ablation candidate. And we looked at a small cohort of those patients here who had oligometastatic, or what we call kind of that rogue lesion. And actually they had a 2-year OS of 76%. So some patients went almost 3 years without needing any other therapy after management of just that one tumor. And here's an example of a patient. So here's this here was ablated. That's what it looks like on what's called diffusion. So it's bright white. Post, you can see it almost looks like it's bigger, but that's actually just the ablation cavity. It's kind of just like a crater. And then you don't see anything active here on diffusion. There, like I mentioned, there's other ablation-like techniques being explored. None yet have a whole lot of data in metastatic uveal melanoma. And then also focused radiation can also be used when lesions can't be easily accessed by other modalities. So pivoting now to clinical trials. I was trying to figure out which graphic really was most appropriate for illustrating all of the layers that we think about when we talk about clinical trials with patients. So, the availability, is there just a trial that exists? What is the inclusion criteria? What is the exclusion criteria? What phase of the trial? Is it a phase 1 trial where we're only going to get one slot every month or two because you need to clear a cohort to find a safe dose, and then they'll only allow 3 more patients on? Is it a phase 3 trial where there's a randomization arm? The trial logistics, the schedule. How frequently do you have to be there? Do you just come in, take your pill, go home, or get your infusion? Are you here for 14 hours? All that kind of stuff. Are there biopsies involved? What are the side effects, and are they in line with, what a patient is willing to experience? And then, really just practically the time to start treatment. If it's an issue of slot allocation, it could be months until a slot becomes available. If slots are available, the time it takes to come in, consent, screen, and then start, at minimum, it's normally about 21, 28 days. So all of these things really need to be considered, when you say, okay, clinical trial. I will say that clinical trial availability in metastatic uveal melanoma ebbs and flows. I think a year or two ago, there was so many trials. It was kind of like hard to pick, and lots of trials for all different patients, every stage of the game. We're in a little bit of a lull right now. So at least in the US, as of this week, I think there's only one liver-directed trial that's actually here at Jefferson, and we are about to finish enrollment very soon. When it comes to targeted therapy trials, there's this trial called DYP-688, which is open, but slots have been hard to come by. Moffitt actually has probably the most in the way of trials right now with these 3 trials. One's a radiation trial, and 2 are kind of looking at drugs. This is a drug that's used in breast cancer. This is another drug that's actually approved in cutaneous melanoma combined with other things. This is probably the most important trial right now for the uveal melanoma community. This is the first-line Daro-Crizo trial that I mentioned already. And there's this other phase 1 study that's open at a few sites. And then for immunotherapy trials, there's a couple of TIL trials. There's a drug called lenvatinib plus Pembro. There's a trial looking at something called tumor treating fields. And then there's this other trial of cemiplimab, which is immunotherapy, and then a kind of a vascular inhibitor also at Moffitt. So, I would say kind of compared to, like I said, a couple years back, there's not a whole heck of a lot that's going on, at least trials that are open even at multiple sites, but more are coming. So the last bit of that kind of, not pie, but the four parameters, and then the one in the middle of logistics, I just really want to highlight, because I think sometimes we forget that, while HLA status is important, where the tumors are is important, how quickly things are growing is important, clinical trial availability, if I didn't already say, that's important. What's really important is the patient. And, with the field kind of evolving and, like I said, becoming more and more complex with standard care options, with kind of off-label options, with clinical trial options, you really do need to weigh things like patient priorities, needs, wants, preferences, quality of life concerns. Is the patient still working? So, if a patient's still working, then a clinical trial, and the patient needs to be working, then a clinical trial where they need to be in a different city 3 days a week is not feasible. Distance to getting that treatment, other medical issues, insurance, cost, things that we really don't want to have in the equation. I mean, I hate to even ever have to make a decision based on those things, but sometimes it's just the reality of it. Family, commitment. I put on their vacation because, I've had a couple of patients that, we talked about a clinical trial. And it's like, okay, we're going to start, July 1st. And then you need to be back on day 8, which is the following week. And it's like, oh, actually, like that's the 1 week my family goes on vacation. And we don't ever want to get away in the way of patients being able to spend quality time with their family. So there's times literally where we will shift an entire clinical trial enrollment or postpone something or move something something up, to be in line with whether it's vacation or someone's graduation or things. So, these are the logistics things that, I know for me are a lot part of what the conversation is when we're actually choosing treatments, in addition to all of the science and all the other things, because I think it's really important. So I was asked to kind of just mention the comment about monitoring while on treatment. So you're on treatment, how should you be followed? And it really varies depending on the treatment. Clinical trials may scan as frequently as every up to 6 weeks or up to 12 weeks. It may also change depending on how long on the trial. So there's some trials where if you're on for like a year, you may be scanned very frequently that first year, and then it actually extends. Our practice, kind of for metastatic patients on the whole, is it to scan it about every 8 weeks. And we do CAT scan chest, MRI abdomen, CAT scan pelvis to kind of get the bulk of where uveal melanoma likes to go. But that can vary post radioembolization or PHP, given there's different treatment intervals. It can vary if it's during immune checkpoint inhibition or TEBI induction. It can vary if patients are on a treatment break. That may shorten or lengthen the interval. Sometimes we add other imaging modalities, so MRI of the brain, PET scans, sometimes MRIs of different other parts of the body, specifically like the spine or hips or things like that. And then I think one of the take homes is that, if you're starting a new treatment, you really should have scans within a month of starting that new treatment, because it's really important to get the best baseline, as things can change quickly. So you would say you were going to start a new treatment tomorrow, being June 22nd, and your last scan was April 4th. While it seems, like a lot of work to get another scan because it was just in April, what if there's been a lot of progression since April? Now you start on treatment tomorrow, you may next get your scan in 2 months. And if there's been progression since the scan in April, you have no idea if that happened between April and when you started treatment, or that the treatment's just not working. So very important for us. We were really kind of strict about that, about having scans within a month of starting the new treatment. And then changing treatment plans of progression. I think this is a discussion best had, with a multidisciplinary expert team, or at least with your oncologist who's communicating with a multidisciplinary team. Sometimes there's rationale for sequencing. So sometimes there is rationale for going from A to B versus A to D. Awareness of trial eligibility. So there's sometimes you need to be exposed to something in order to be eligible. On the opposite, sometimes if you are exposed to something, then you're not eligible. And then liver control should try to be maintained through all of it, because that unfortunately, as I've mentioned, is the thing that can sometimes get out of hand and become life-threatening. So kind of in conclusion, the diagnosis of uveal melanoma primary can be overwhelming, but certainly the diagnosis of metastatic uveal melanoma can be overwhelming for, I say 101, but I'm sure it's more like a gazillion reasons. And I think having connection to a knowledgeable medical oncology team from day one can often expedite diagnosis and treatment. So just as Dr. Berry, was saying, there's a lot that can happen in that first week or two, and it's nice to already be connected. Biopsy should be attempted if tumor is suspected. HLA should have been done during surveillance or immediately once metastatic disease is expected. While there's a number of FDA-approved therapies, access to these can still be a challenge. So whether it's tebentafusp specifically or Hepzato specifically, these are not therapies that are being offered everywhere. So access can still be an issue. And having an understanding of the trial landscape can be helpful if sequencing is needed. And like I said, to avoid things or get exposure to things. And then I really do think it's important to have a treatment plan that considers the logistics. So all the other stuff to work with you to develop an approach that is best for you. And that is it. So as a patient, what can I focus on if I'm stuck in a waiting period, either between scans or treatments, or unable to have a definitive biopsy right away while navigating? This is a tricky one. I say that the limbo between scans, so maybe you haven't had a metastatic uveal melanoma diagnosis yet, but you're high risk. So really the anxiety between scans is real, or there's been a scan that says, there's a little something that we don't like, but it's too small to biopsy. We're going to have to get another scan or something like that. I mean, I think that's probably, and I don't want to speak for patients, for sure, but it's almost worse than kind of having the diagnosis and having a plan, right? Everything's better when you have a plan, and that could just be a very uncomfortable place to be. And it's easy to say, well, just don't think about it. Just go about your life and just do all your things. But that's obviously easier said than done. What I always tell my patients who certainly are in that kind of limbo zone is, listen, we're gonna figure it out. Whether it ends up being something or ends up being nothing, we're gonna figure it out. And, I know that and for some patients, getting data and knowledge is super helpful. So they go to the internet and they research as much as they can, which is fine. But I always try to give patients the comfort in knowing that's also my job, our job, our collective job as, specialists in the field, medical oncologists, across the country and beyond is to know what's going on, right? And to have a plan, when a plan needs to be implemented. So I don't know, that's not really an exact answer to your question, but
it's kind of a nuanced question, I think, for sure.
It's a tricky place to be, but you just have to kind of make sure you're in with the right people and just kind of trust that, they will make the right decisions with you, certainly. There's a question about mental health supports for patients who are navigating diagnosis, treatment, and care. I mean, I can't speak more highly about the advocacy organization. So a number of advocacy organizations, I know Cure and Sight has patient support groups. I know that's not necessarily kind of mental health support, but every cancer center normally has either social work or even kind of psycho-oncology that can help kind of navigate patients more individually, through all of that. If your cancer center does not, even so much as talking to your primary care doctor and getting a referral to, a psychologist or a therapist can be beneficial. So I'll jump to this one. So what are the benefits of spot treatment versus a whole lobe treatment in liver-directed therapy? Any data to support one over the other and how patient presents and tumor burden kinetics, genetic indicators? So I don't know if that means spot treatment, meaning like ablation versus whole lobe. So liver-directed therapy kind of in general, whether it's, immunoembolization, chemo and radiation or PHP, really treats the whole liver, at least in pairs or at the same time. Whereas things like spot treatment, so there'd be ablation, radiation or some of the other kind of local techniques. I think the benefits of spot treatment are sometimes it can just be a one and done. You're giving a lot of treatment to that one area, but it obviously doesn't treat the whole liver. Whereas if there's multiple tumors, then spot treatment's not a good idea and you want to treat the whole liver. There's also some thought that some liver-directed therapies, so certainly even something like PHP, where you're really saturating the entire liver, may also be killing cells that you can't see yet radiographically. There's no genetic indicators, though, that really have guided us in liver-directed therapy world yet. All right, so moving on to Leslie's question. I am A negative with no Mets. What is involved in the Daro-Crizo trial? Is it an oral medication or more complex than that? Where is it being conducted? So it's kind of a long question. I said, hopefully you'll just never need any of this information, but it's being conducted at various sites around the world, actually. So lots of sites in the US. It's like I said, it's a randomized trial. So kind of 2/3 of patients get randomized to the Daro-Crizo, which are pills that you take every day. And then the other patients are often randomized to Yervoy and Opdivo, which is an infusion that's every 3 weeks and every 4 weeks. There are some kind of extra little testing that has to happen with doing like EKGs to monitor your heart and blood tests. But certainly anyone who's interested in that trial, I encourage you to speak with a physician who's participating to see if you're eligible and what else goes into it.
Wonderful.
See a look on time.
We've got about 5 minutes.
Yeah. So what are some of the local expert centers in the US with uveal melanoma medical oncology presence? I believe the Cure Site has that resource somewhere.
It's a little tricky. The physician finder on our website, Dr. Barry referenced, I don't believe that we have a medical uveal melanoma oncology like specifics. I think it mostly focuses on ocular oncology. So I guess this was more of a question. This is actually from me. Just like, I know we know of Thomas Jefferson. Yes. You mentioned Moffitt Cancer Center. And so I'm going to assume those are two kind of regional locations. But if we could, pinpoint maybe an area where of uveal medical oncologist in the Midwest, and then I know my doctor out here in the West, that way we could kind of just show people on the map.
Yeah, I mean, I always appreciate this question. I just also don't ever want to leave anyone out because I think there's
it's so hard.
There's a lot of centers, and I definitely don't want to leave anyone's centers out. But you could probably think of almost any major academic center right now in the U.S. There's obviously the sites in Boston, sites in New York, here in Philly, Baltimore, Atlanta. I'm just literally going down the map in North Carolina and Charlotte. And I'm also really bad at geography. So do not penalize me. A couple of sites down in Florida, Texas, Colorado, Ohio, Arizona, obviously California, Oregon. I mean, there's definitely some states in the Midwest, like no, there's not really an expert site in North Dakota or South Dakota, and those patients often have to travel. But, I think this is where going to some of the patient support groups, and you could probably geographically hear about kind of, who's open, or actually just going on clinicaltrials.gov. Honestly, if you were to look to see which sites are offering the drug alternative trial, that's probably a site that sees, uveal melanoma, because then there's some places you don't think of, like University of Iowa. It turns out that, they see quite a bit of uveal melanoma and have this trial. So again, I don't want to leave any sites out because I think there are a lot of sites that see a decent amount of eye melanoma and have a lot of options for patients.
Yeah. And I think, like you said, it's ever changing, ever growing. And I think it's just important that patients recognize, hopefully, that there is something on the map that they can locate, and it doesn't necessarily have to necessitate them traveling from East Coast to West Coast. There may be something in between.
Yeah. Yeah.
Okay, wonderful. Well, do you want to pick one more question, and then I can send you the rest of these via email?
Yes. Let's see here.
There's a liver transplant question. Do you want to cover that one? That's an interesting question.
I can. It's a softball. So no. So liver transplant is not an option for metastatic uveal melanoma. A lot of patients ask that because if you were to Google liver cancer, liver transplant's an option, because in that case, primary liver cancer, right? The cancer starts in the liver, whereas in uveal melanoma, the cancer travels from the eye to the liver. So it's basically assumed that cells are circulating. So just by transplanting the liver, you're not really going to eradicate cells that are floating around. And then you have to go on immune suppression, which is also not good. And, the cells in theory can just kind of hone their way back to their liver. So
Yeah.
we do not, you can't, that's not an indication in the US for liver transplant.
All right. I think that covers it, unless you see one that you're dying to answer right now.
Yeah, I think that's pretty good. I can answer the other ones offline.
Awesome. Well, I will go ahead and get those answers from you sometime in the next week or so, but please, thank you. Well, thank you so much for being here, for your time, for your expertise. Thank you to our audience for being here. And I will go ahead and dismiss you, Orloff, so you can get to the rest of your Friday afternoon.
Thank you. All right. See everybody.
Bye. All right. Well, if you guys are still here, hang out for just a sec so I can give you some housekeeping announcements and we will wrap it up. So just by way of your information, if you didn't know this, if you didn't come across the registration link for this webinar in a way that you had hoped, please register at our website. You can go to acuresite.org, and at the top area of the website, there's a little button that you can push that allows you to register for our newsletter. Our newsletter goes out every final Friday of every single month. And then we also will push out just news releases, press releases. So this is one of the best ways that you can stay in the know on what is going on in the uveal melanoma space right now, this month. What's the new data? What kinds of things should you be aware of with your doctor? So please make sure to subscribe to the newsletter. Head to the website at acuresite.org, and you can just find that little subscribe to the newsletter at the top area of the page. Our website is also a wealth of information. Dr. Barry mentioned the clinical trial finder, or the physician finder. Dr. Orloff mentioned the clinical trial finder. There are so many resources, and if you have feedback for us and would like to send us that, please send us an email at contact@acuresite.org. Finally, if you're here, you're listening, you're watching here live on the webinar, thank you again for being here. Go tell a friend to register for the next webinar when you see it. Make sure to help us share those posts on social media. And if you have not already subscribed on the YouTube channel for Cure Insight, or on one of the podcast listening platforms, depending on your listening preference, please make sure to go ahead and subscribe to those platforms so that you can stay up to date whenever we release a new episode or we have a recording that goes up from something like this webinar. By way of just final quick announcements, we have major events coming up in the next few months. Our first event to be aware of is our patient meeting. That is the I Believe patient meeting, the I Believe Survivorship Seminar. It's going to be hosted here in my hometown in the Scottsdale, Arizona area by Dr. Justin Moser with the Honor Health Research Institute here. And we are thrilled to be here in Scottsdale. We hope you will make the trek. It is in October, and as an Arizona living in the sun, Omi, I can tell you October is when it gets much more pleasant. So we're going to be there mid-October. You can find the details on our website. You can also just reach out directly if you have questions or find our social media posts regarding registration for I Believe. If you're not already aware of our 5Ks happen all around the country, and I believe we have a few coming up the remainder of the summer. We've got one coming up in Palo Alto in July. We've got a Seattle 5K coming up. Later in August, we have other dates happening, and if you head to lookingforacure.org, you can find out if there is a location near you. We would really encourage you, patients, to be there. Caregivers, pharmaceutical companies, representatives, encourage your doctors, your community to be there in person education, but also to fundraise for us, because we cannot put on these events without fundraising efforts. We have to be our own advocates in ocular melanoma, and that can be really hard and really draining. And so just finding the ways that we can rely on community support can be huge. We appreciate all of you who have made the trek out to the 5Ks. This year we have some special 5K medals that are going out for just survivors, for ocular melanoma patients specifically. So if you haven't gotten that special medal, please make sure to make your way to a 5K in person. And those are given out to patients during the events. And lastly, if you guys have just a quick minute, sometime this month or at a future point in the year, really you could do it whenever you choose, anniversaries, your birthday, any other kind of time in the day. If you're on social media in any capacity and you're willing to make or learn how to make a social media fundraiser for us, then we would love it if you would help us fundraise for Cure in Sight so that we can continue funding things like these webinars, patient programs, patient financial aid, and of course, funding critical research for ocular melanoma. We can't do this alone. We need your guys' help. We need our patients and our caregivers. We need the community coming together. So thank you for listening to my TED Talk. Thank you for being present for the webinar today.